lives?
All of the above, Rachel.
Right, thank you.
Okay, I'll start the webinar now. So Clive, over to you.
Thanks, George. Thanks, everybody. We've still only got 5 participants at the moment, so. Well, welcome everybody to the Liberty Protection Safeguards webinar, as these apply or will apply in supported living and extra care settings. We'll start the webinar as soon as the numbers joining have stabilized and slowed a little. So just a moment or two and then we'll get started. Okay, I think we're probably there. So again, welcome everybody to the webinar. This is the last of 3 sessions. Our previous 2 webinars looked at home care and care home settings. The webinars have been organised for our members by Care England, the National Care Forum, the Registered Nursing Home Association and the Association for Real Change, that's ARC. So we're trade associations and members of the Care Provider Alliance, and we represent a full range of types of providers of services in the social care sector. We're grateful to Rachel Griffiths, who is an expert in Mental Capacity Act and the Liberty Protection Safeguards, and who'll be presenting today. We are recording the webinar so that we can share this with others who are unable to attend, and the recordings and the slides will be uploaded to the CPA website. Please put your name and your organisation and role in the chat box so we can get an idea of who's joining us today. That'd be really helpful. Thank you. So we want to spend about half our time on questions. So we will have a presentation from Rachel, and then we'll have hopefully half of the time we have together today for questions. Please do use the Q&A function for questions rather than the chat function. The chat function is quite difficult actually to monitor for questions. So if you could use the Q&A function, that'd be great. And the reason we use that is if we're not able to answer a particular question today, we will include it in a Q&A document, which we'll produce and circulate after the webinars. So just the final thing to say is this is very much an awareness session. So it's intended to introduce you to the new safeguards, and the code of practice is where we're going to get into the real meat and the detail of this. So at that point, I will hand over to Rachel. Rachel, welcome.
Thank you very much, Clive. Hello, everybody. Thank you very much for giving up your time to learn something about the Liberty Protection Safeguards. I say learn something, note, not learn everything, but you'll see why as we get started. Could I have the next slide, please? So these are the things that we're going to look at to the best of our knowledge, what is going to happen and when, and what will it mean for, I hope, the group of people who are listening today and part of today. Very importantly, what can we do to get ready? And perhaps even more importantly, a link to some resources and reasons not to panic. Next slide, please. So this is just the absolute headline. The way that people's human rights are protected when they are in a very restrictive care plan that is depriving them of their liberty is going to change. We are going to lose deprivation of liberty, which never applied to, I think, most of you on the call today, to liberty protection safeguards, which will. Next slide, please. It's important to remember that everything I'm talking about today only applies to people who lack capacity in the terms of the Mental Capacity Act. So it's decision and time specific, which I always think of as, can this person make this decision at the time they need to make it? Because if they can't, the Mental Capacity Act lays out how that decision is reached. It only applies to people who are 16 and over. and it will only apply when what they lack capacity to do is to agree to the what LPS calls the arrangements. I think almost always that's exactly what the rest of us call a care plan, which is needed to give them essential care or treatment, and if it amounts to a deprivation of their liberty. Next slide, please. So, $64,000 question, what is deprivation of liberty? This got clarified for us in 2014 by the Supreme Court, which was very helpful. And you will hear people talk about this thing called the acid test, which is that the person is under complete and effective supervision and control, meaning that staff or carers know pretty well what the person is doing at all times and where they are, and they're not free. Doesn't mean not free to go out on an outing or even to go on their own to collect their daily paper if that's what they always do, but it means free to go and live somewhere else of their choosing. Next slide, please. And the way to think of why we're interested in this is because however brilliant the care plan is, and after all, it's not going to be authorised, it's not going to be agreed, I hope, unless it is brilliant and the best way possible of giving this person the best life possible. Deprivation of liberty is a human right. It's the same for everybody. And what Lady Hale said in the Supreme Court was a gilded cage is still a cage. I've given you the reference to the Cheshire West case, which you may have tiptoed past because it wasn't much to do with you because you weren't care homes or hospitals. But it's a good read, so you might want to take a look at it. Next slide, please. Now, deprivation of liberty arises really out of restraint, which means that if you are restraining a person who might lack the mental capacity to consent to what you need to do to give them essential care or treatment, you must be aware of what situations where you are restraining somebody. There are still, I think, some people and even some guidance that tends to blur restraint by calling it support. You often, I'm afraid, come across it in the reports into very, very poor care, where people have said, we supported him to effectively go into solitary confinement, though it would be we supported him to spend some time in the blue room. Recognize what it is that you're doing. This is the Mental Capacity Act definition of restraint. I've underlined the bit of it that people tend not to recognize more, which is restricting somebody's freedom of movement. So that locked front door, if the purpose of the locked door is to keep the person in, it doesn't matter whether they've even noticed or whether they lack capacity maybe to understand that they could perhaps go out if it weren't for that locked door. It is still a restraint. And it is worth really being quite rigorous about recognizing restraint and recording it. And always ask, because it's part of the wider Mental Capacity Act, to ask yourself if this level of restraint is both necessary for the person, not for convenience of the staff, and proportionate to how great the risk of harm is to that person and how serious that harm would be. And this is in the current code of practice. There's a good chapter, I think, talking about restraint. Next slide, please. So what is going to stay the same? It's worth us all remembering. It's so easy to get tied up in a new system and a new set of things that have to be done and that can appear a bit bureaucratic. even LPS, which is supposed not to. But this is a very important purpose, and it is protecting people who are very vulnerable to perhaps being over-restrained thoughtlessly, or even deprived of their liberty. So this is to protect the rights of people where they can't consent. It does amount to a deprivation of liberty, so it meets the acid test in their care plan. And it's in their best interests, but also, just like restraint, it has to be necessary and proportionate. And this is where staff get their protection from liability if they are depriving someone of their liberty when there is no less restrictive option. Next slide, please. So what's new? Well, lots of people have been missing out, are missing out on deprivation of liberty safeguards, DOLS, because they only apply in care homes or hospitals. That's now, with LPS, going to vanish completely. It's a totally blurred picture deliberately, that anywhere that the person is living or receiving services, including their own homes, liberty protection, the safeguards will apply. And DOLS does only apply for people aged 18 and upwards, LPS from age 16, which of course brings in some young people of 16 and 17, and sometimes a bit older, who are in children's services. Next slide, please. And you may have come across DOLS, and if so, you will be very relieved to know that LPS is planned to be simpler. I feel that now, and when it's implemented, we may all have a role in reminding the people organising it that this is a major intention, but it hasn't got the rules base that DOLS has got. It doesn't have as much jargon, there's still a bit. It isn't as bureaucratic. It is easier and more flexible and more intuitive and cheaper for the state to run. And I think for providers to deal with, but we'll have to see about that. It can be extended more easily and for longer, and it can be used for a person who's receiving care in different settings, but that does have to be built into the care plan. Next slide, please. Right, so this is the last thing about what's going to be new. Bit of introduction to the jargon of responsible bodies, which will inevitably get called the RB. So it's one of those things, you know, try not to have that blank moment where you think, I don't know what the RB is, the responsible body. It's replacing what's in DOLS, which is the supervisory body, but most of you have managed to avoid them. Expanded role for IMCAs. You will already, I think, have come across independent mental capacity advocates called IMCAs. They will have a bigger role in that they will support somebody throughout an authorization instead of just when it's all being assessed and when it starts. There's a new role called AMCP, Approved Mental Capacity Professional. Say a bit more about that later. If any of you have come across the DOLS Best Interests Assessor, a lot of them are going to be best interests assessors with a slightly different role, but they only get involved if the person is unhappy about being where they are and unhappy about any aspect really of their care or treatment or where they are living, bearing in mind they don't have a choice about it. I mean, it's part of their care plan. Or anybody is in an independent hospital. The AMCP role was added to independent hospitals while it was going through the House of Lords, the bill that turned into this law that brought in LPS. The reason really was that there were a few really alarming, worrying cases of poor practice in independent hospitals. So AMCPs look at the arrangements in any independent hospital. So the reason for that is quite clear, I think, because of the people who may have no speech and autism and learning disabilities. Hospices may get pulled in to this. And I think, honestly, that was probably unintended. But I mean, it's not a bad thing anyway to get the overview of the AMCP. Next slide, please. So LPS will have 3 assessments. DOLS has 6, but actually these 3 cover them pretty well, I would say. But anyway, there are 3. I'm sorry about the acronyms here. The slide would have been too full. So there's a capacity assessment to consent to the arrangements that amount to a deprivation of liberty. Social workers, occupational therapists. I should have put doctors in here. Any doctor, not just a psychiatrist, but any doctor, a psychologist, nurse, or speech and language therapist. They must all be registered members of their profession. This ought to be done, and really almost everything for LPS ought to get done as part of Care Act care planning. You may be a bit skeptical about that, but it's really important that we improve, and that we ask that care planning is done properly and considers capacity and second assessment mental disorder. Does the person have a mental disorder as defined in the Health Act? That can only be a doctor or psychologist. Again, it should be part of the care planning. And then this final assessment, this is a phrase I've used several times already this morning, necessary and proportionate. Now, this can't be a reused assessment. The other 2 can. It must be a new assessment, but this ought to be getting considered all the way through. The care planning ought to consider, are we likely to be depriving this person of their liberty? If so, is it going to be necessary and proportionate? So again, bit of jargon. I don't know that it'll start getting called the N and P. I can only tell you in the Department of Health, they're already doing so. So we've probably got to be braced for it to be called N and P. But this is at the heart of LPS. Next slide, please. So what does it mean? Well, care homes and hospitals, pretty small changes actually. Still dealing with the same local authority. Yes, there will be differences, but not enormous. It's a much greater learning curve for any other setting, including, of course, some domiciliary care, but we had a session really dedicated to home care providers. So really, the name of your service doesn't much matter. It's more what you do. So whether you're defined as supported living or extra care housing, there may be services that provide very different levels of restrictive care, because that's what is required by the people that this service has the expertise in helping to care for. So currently, I think this is an important point. Already, if anybody age 16 or over is deprived of their liberty in any of these services, the commissioners or the local authority, it's often the same thing, should be applying to the Court of Protection. It still needs to be authorised. It's not being. The Law Commission, prior to the LPS bill being drafted, reckoned that there was quite a lot of probably unrecognised deprivation of liberty. And sometimes it is recognised, but it's very stressful, very expensive, very time consuming to go to the Court of Protection to get it authorised. So I think unavoidably we have to bear in mind that there probably are people whose rights are not being protected now by the current system. And that's something to look into, actually, when you get a spare minute. But importantly, once LPS comes in, these people will have their rights protected, and you will be having to work within an LPS kind of framework. So it'll be some new processes. It's important to know you will not have to carry out the assessments or the authorization process. You will not actually be responsible for deciding whether the person even is deprived of their liberty. But it'll be a good idea for you to be able to recognize when they might be, which again, probably should be happening now. Next slide, please. So practical implications. You should be working already within both the Mental Capacity Act and an understanding of deprivation of liberty. I think the wider Mental Capacity Act is absolutely crucial, and it's the framework for decision making in the absence of capacity. Many of you won't be involved often in working within this framework at all. Others of you very much will be. I'm thinking of learning disability providers who are likely to be providing pretty restrictive care plans for many people. But other providers, for example, there's a wide range of housing providers who may come across this, but in many of them, people do retain a huge amount of their own autonomy and do things their own way. You are going to have to maintain and understand records of LPS and understand what it is and that it's a good thing and a protection for the person. If you are going to be involved, you will have to, like the care homes, have to recognise that assessors and IMCAs will visit specifically for DOLS purposes. You will have to be prepared to welcome assessors and IMCAs. Again, there are data protection implications there, but I don't think we need to go into them today. I think that they're pretty obvious. Make information available basically on a need-to-know basis. And CQC is going to be monitoring LPS. That's for people who are not in children's services. There it's going to be Ofsted. They are going to, I mean, many of you will have LPS coming and will have CQC involvement anyway as part of your registration and your existing oversight. But some of the settings that are not currently monitored will have to recognise that. I think this will be looked at during inspections. I mean, it should be the case now. CQC can only visit settings by invitation if they're unregistered. So that's still being worked out, but people in their own homes or housing with care or shared lives settings, I think the important thing will be to recognise that anybody involved in the LPS process is a colleague, not a threat. Next slide, please. This is a horrible slide. This is because you're going to be sent these slides afterwards, and I don't know quite where you all are and what type of people you're providing services to. So this is one bit of LPS which has got more complicated, except in Wales where it hasn't. So these responsible bodies, if the person's care is mainly in an NHS hospital, it's the hospital manager. In Wales, it's exactly like dolls now, it's the health board. Clinical commissioning group, the law currently, with the law and the current draft code of practice still talks about clinical commissioning group, even though they're in their last couple of weeks, I think, of existence. So in future, it will be the Integrated Care Board, which will be the responsible body for people receiving NHS continuing healthcare. In Wales, it's the health boards. But for most of you, most of the time, it's going to be the local authority in England and in Wales, and also in England if you're an independent hospital. This is kind of headache territory. It's written down in the draft code of practice. It'll be in the proper code of practice. And if in doubt, don't worry too much about that. Next slide, please. Because there is a no wrong door principle. We will do our level best to get it right. The responsible bodies must not be awkward. They must all cooperate and pass it on. If by chance you've sent it, maybe in the early days, they'll get quite a few. I think after that, it'll probably become fairly obvious. But I think the underlying point is be colleague-ish, if that's a word about it. But the local authority and other responsible bodies, if you have told somebody in the wrong responsible body, they are not allowed just to sort of rip it up or put it at the bottom of the heap. The responsibility for identifying a possible deprivation and referring it to the responsible body is for everyone. Now with dolls, the care home manager has a big responsibility for doing this. They're the people that have to trigger the process. This can be triggered by anybody, a neighbour, a visiting healthcare professional, care providers, of course, you're in a good position. There are no statutory forms or process for a referral. However, I've got to say draft forms are wandering about in the system, but they won't be statutory. And I guess it's a good idea to have some way, some sort of a form might be helpful. But I mean, somebody's neighbour isn't going to seek out a form. So again, the responsible body has to find out the information it's going to need about the person. And then that responsible body is responsible, clues in the name, for the entire process. There isn't a timescale for them. There's a suggested one in the code of practice, but there isn't a statutory one. The only statutory one is here on this slide, which is informing the person who's been deprived of their liberty and their relatives and friends who've been consulted about it within 72 hours. And even that, nobody's entirely sure if that's 72 working hours, as it were, or not. But anyway, again, it's one for them to worry about, not for care providers. Next slide, please. When's it going to start? Well, we still don't know that. 2 deadlines you may have noticed have come and gone already. I think there's some excuse, what with the pandemic. But I have to say, I think the first one slipped because of Brexit. Next one slipped because of the pandemic. It can't be before autumn of next year, maybe spring of the following year. And the timetable does allow, and the government plans allow, for 6 months at least of pre-implementation training. By training, they mean that resources will be available, I think. I mean, there'll be the new code of practice, there'll be a lot of training material provided free by Skills for Care, Sky, Health Education England, the Association of Directors of Adult Social Services. There's going to be free material available, and that's not going to start until after next winter. We're not quite, are we, at the shortest day Well, maybe we are. Anyway, winter will come soon, but after next winter, training will be available. Next slide, please. This is the government's current timeline. So we're in the middle of the first bit, the public consultation on LPS, which finishes on the 7th of July at 5 p.m. It's engraved on my memory because I'm producing responses. I also encourage you all to have a look. I've given the link at the end of this presentation to where you can have your own say on the consultation. It is a lengthy wodge of documents, but there's a very good summary. And if there are bits that you can take a look at and give them your opinion, I know that they really do want that. And they've allowed a lot of time for consultation, for consideration, right through to, well, right through the autumn. They're going to be sifting and going through, and then they will publish in the winter sometime, maybe early winter, maybe late, they haven't committed, so it could be in the spring, the code of practice, and then they're saying we have 6 months to be getting ready for the launch date. So we will let you know when we know a launch date, but I think we won't know it till the winter. I can't see how we can. Next slide, please. And this is the government's training triangle. You will see that the arrow on the left is getting more specialised, right up to the AMCP, the approved mental capacity professional, up at the top. And the arrow on the right is numbers of people who need to be trained. So care providers, I think, always come into A, and care home, care provider managers into B, identification and referral. So A, awareness raising, we're doing that a bit today. There will be a lot more available about how LPS fits in the Mental Capacity Act. So, I mean, we are doing that today. We've done a little about identification and referral. So you see, we're on the way. But the assessments are for those registered professionals, and then there's a pre-authorization review, authorization. There's the role of the IMCA, which is simply right up there because they're extremely important, and there are going to be more of them than there are now, but they come in at a certain stage, and then AMCP. Next slide, please. So the consultation, do let them know what you think. I mean, our views are important, but yours are gold dust for them. Bearing in mind, the ship has sailed on whether you could say, I don't want LPS at all. I mean, I think that one has gone by, but it's got to be practical and practicably possible for us to work in it. And they are still sometimes quite confusing, I think, about what they expect. Next slide, please. This is a reminder really of the importance of LPS. It is not a bad thing to deprive somebody of their liberty if it is the least restrictive way you can meet that person's needs. And if it's going to keep them safe from serious harm, and they do need care and attention. So the safeguards, LPS, liberty protection safeguards, this is nothing to do with adult safeguarding. Incidentally, I'm sorry that the name does lead people to think that it's part of safeguarding. Absolutely isn't. It's part of a kind of human rights strand about rights rather than the kind of adult safeguarding approach sometimes. So identify if somebody might be deprived of their liberty, give them some advocacy, which is always good if a person hasn't got somebody to speak up for them. Have the checks about whether they do lack capacity, do have a mental disorder. It's like a building inspector, you know, was this care plan built right? Or does this person in fact have the ability to make their own choices about their care? And the vital, necessary and proportionate. And it gives people a right to review and challenge, which is a good thing. I think we should never feel threatened if somebody takes up their right to challenge an authorization under LPS, because it is part of what is built in, because it's a serious, intense invasion of that person's human rights. Maybe we've all got it wrong, you know, it's possible. So they do have a right to have it looked at by a judge. Next slide, please. Right, to start getting ready, the basic Mental Capacity Act must be at the heart of your service. I've given you the 5 principles here. I'm sure that certainly those of you providing care to a lot of people who might lack mental capacity for some decisions are working within these principles already. But there may be some of you who haven't come across it as much. And these 5 principles are statutory, they're part of the law, they are essential if there are any question marks about somebody's capacity. Next slide, please. So ensure that your staff are confident about the Mental Capacity Act. The Mental Capacity Act really is intuitive and arose out of existing best practice. You might be thinking, well, she would be saying that, wouldn't she? But it really is the case. But ensure that the voice of the person, I've put here the voice in quotation marks because people may not have speech, but there are ways of communicating. And people who know them best and love them in their families or friends are gold dust sometimes for finding out things that we just don't know that they've learned over time about what the person likes and enjoys or dislikes. And always think about any restriction before you fret about whether it's a deprivation of liberty or not. Ask if it's necessary and proportionate and record why you think so. By record, just write down. It feels necessary because of the risk of harm and proportionate to the risk and the seriousness, which would be getting run over or whatever it might be. This is something that is helping the wider system more than it's helping you. But if you collect any assessments that come your way, because these assessments of capacity and mental disorder can be reused, they are gold dust in the system, and you will be immensely popular with the responsible bodies if you can point them at some assessments that maybe could be reused. And later on, not now, but when there are local implementation groups, join them, get to know the faces and the person, recognize the individual so that you can ring them up and ask them questions. Next slide, please. These are the basic resources that you need. I've also mentioned Sky and Skills for Care, public consultation, government fact sheets and latest news. Any of you in Wales, you've got not only this consultation, you've got an extra one of your own, taking up your time, but again, it's probably worth having a look through it. Next slide, please. For those of you like me who think sometimes in pictures, LPS puts the person at the heart of everything, and what everything is for their care plan, if they might lack capacity, is the Mental Capacity Act, which in itself is part of human rights. which are not a bad thing. Certainly in health and social care, that's certainly not a bad thing. Next slide, please. So the reasons not to panic. It is a bit complicated here and there, but it's intended to be simple and flexible. The person is the most important, and hearing their voice. It is more intuitive than dolls and less bureaucratic, not a high bar, you would think. Dolls was pretty tricky, and still is, of course, till the implementation. And it protects people who really do need these protections for their rights. Next slide, please. And we are now on to the Q&A. I'm sorry I've gone on longer than I perhaps should have done, but I felt some of that at least was important. I will do my best to answer your questions. Questions that I can't answer, we will answer in writing. Clive, back to you.
Thank you, Rachel. So there's a lot there. We have a number of questions. I'll start with the one that came from Shirley. Shirley, you asked about day services. Initially, your question was whether or not the liberty protection safeguards would be extended to day service. And we've already answered that question because the answer is yes. But your next question is about whether or not day services are grouped along with education. And what Shirley's asking is, she's not sure because she thinks that day services for education would not be for older persons daycare, and would they perhaps be monitored by Ofsted?
Aha, that is a very good question. Certainly a young person who is going to say college some days a week could be deprived of their liberty under LPS, either where they live or at the college or both. So they would be considered separately. I think those colleges, almost undoubtedly, I think I'm right, that they will be monitored by Ofsted, but the responsible body will still be the local authority. Yes, it will be the local authority. If in doubt, assume it's the local authority. They are the fallback for any setting that you can't think where it is. That's not just me passing the buck. It's actually part of the way the system is set up, that anybody that they haven't thought about, because services change. But yes, the local authority is the responsible body, and the monitoring body will be Ofsted, if it already is Ofsted, and it probably is. If it isn't, then I don't know, and we'll get back to you on that.
It is an interesting one, isn't it, Rachel? Because many of the people would be adults being supported in day services, so we can maybe take that one away and have a look at it.
Oh yes, adult day services where there's an educational component, I think is much simpler. I think that would be the local authority and CQC. If it's thinking about different types. I mean, certainly the kind of day centres that I, as a learning disability social worker, used to have a lot to do with somewhat the colleges, but far more the actual day centres. And there it would be the local authority. And so CQC would be having the oversight on that one.
Thank you, Rachel. Question from Jane Gale. This is about, it's a similar question in relation to CQC versus Ofsted. This is about shared lives. So in some shared life services, people who are under 18 are supported. This is normally okay with the CQC. Will Ofsted monitor these cases, or will that be the CQC?
I think it will be the CQC, but I will look into that. Can you remind me, Clive, to put that? We are sending out a list of questions and answers that I will have thought of, not just off the cuff. I believe that will be CQC, but I will look into it.
We'll check into that one. Thank you, Rachel.
I mean, the monitors, you will know who is monitoring it. nearer the time for sure, and your responsible body will certainly be the local authority. As to the monitoring, I think I need to try and unpack that one in my own head.
Thank you. So thinking about the capacity assessment, Rachel, will that still be the provider assessing capacity, or does this need to be somebody else under LPS?
There are two answers to this. Day to day, of course, the provider is assessing capacity almost in a sort of ongoing way with some people who might have learned to have capacity for some decisions that they couldn't make before a well-targeted, built-up series of learning interventions. So this isn't taking away your right and your privilege, really, of making these decisions for yourselves day to day at all times. But for the purposes of LPS, there has to be a specific capacity assessment done by one of those registered professionals. And the assumption is that that will be done for new people coming into a service as part of the care planning process. So Care Act, care planning, LPS will march hand in hand with it, and the capacity assessment will be done at that stage.
Thank you, Rachel. Regarding the AMCP role, is this going to be a specialist role, or do you think that it'll be picked up by current health professionals?
It is a specialist role in that it's going to have specialist training provided by universities, like best interests assessor training currently is. It will, I mean, given that the people have to be one of those professions, it's nurses and social workers, and the new one is speech and language therapists, which I think is a good addition. I think honestly they just forgot about them when DOLS was being created. So they will, it's not, you cannot be an AMCP unless you've been recognised by the local authority as an AMCP. So, and in order to do that, you have to have had some training, which is specific. So both really, it is there will be local people. They may be formed into specialist teams of AMCPs, or they may not. There's a suggestion in the Code of Practice about that. I myself think it's unnecessary, but they might do that. But it will be like best interests assessors now in the DOLS process. And maybe that analogy is not helpful if you're not coming across them. But yeah, I hope that, do you think I've answered that? If I haven't, come back.
Yeah, if we need any further clarification, just type that into the Q&A box. Question about how the CQC is going to monitor non-registered services. Do you have any insight into how you think that would work, Rachel?
Tactfully, I rather think. They have two monitoring duties. The one that's quite simple in a sense is there's a thing called the Optional Protocol to the Convention Against Torture, called OPCAT for short. CQC is part of the United Kingdom preventative mechanism, it's called, for the country to prevent unauthorized deprivation of liberty and hear the voice of the detained person. So in order to do that, they have to write a report annually on the whole system and how the whole system works. That's one bit. Another bit is that as part of the regulations for LPS, anybody, including extra care housing, for example, organisations will be expected to give figures to CQC so that they can write these reports, so that they will know how many people are deprived of their liberty. No, they won't. I'm wrong there. The local authority collects all this information. So if the local authority is your responsible body, they will collect the information, they will give it all to CQC. You don't have to. Whereas currently with DOLS, you have to do a real-time notification to CQC if there's DOLS activity in somebody's care plan. That falls away completely. You won't have to do that at all. So it's just that the local authority that will be the responsible body, or the other responsible bodies come to that if it's one of the others. If it's a person with NHS continuing healthcare, it would be the Integrated Care Board. They collect figures on what's going on. Now, as to them meeting the person and coming and looking, they can ask if they might, and I think there's quite a good argument to say that if you're running a service such as a housing provision with extra care support built in, why wouldn't you let them in? I think honestly that's still being sorted out. That sounds as though I'm just passing the buck and don't know. I will look into it and find out what the latest information on that is. But all I can say is we've still got a year and a half to go. I think there is a real problem about going into people's own homes, and CQC is very clear that LPS does not give, well, the system is very clear. LPS does not give CQC a right of entry into somebody's own home. They can ask and they can come in by invitation only. So I think that one's got to get bottomed out a little bit. There's really good questions.
So this one's about whether or not LPS is intended to be location specific, or is it an authorization that can follow the person to different locations?
When it started, this is an excellent question. When LPS was going through Parliament, a big fuss was made of the fact that it would do just that. One authorization would follow a person around. To some extent it can, but the way the law has ended up, so what we are stuck with is that if you plan it in advance, that's fine. So if you know that somebody spends 2 days a week in a hospital, but their main care is in a supported living setting, so the responsible body, incidentally, will be the local authority, even though they're 2 days a week in hospital, say for dialysis or something like that. If you know that's going to happen, you can build that in. So you can build in daycare, you can build in respite, you can build in hospital, and it will stay, it will sort of run along. It can also cover transport between those if the person is sometimes resistive to going, that can be authorized as well. What can't be authorized is if the person slips and falls and breaks a bone and it goes into hospital and it wasn't predicted, so it couldn't be predicted, so it's not in the care plan, then it is not covered and you would need a new one. Now, there is the suggestion in the Code of Practice that the existing one in the, let's say, supported living, because that's not quite as amorphous and blurred as some of the other settings get. You've got a person in the supported living setting, they have some medical accident, they have to go into hospital for more than just sort of 72 hours or so. They have to be there 2 or 3 weeks. They are deprived of their liberty there because they need quite a lot of supervision and control to keep them safe there. There is the suggestion that the existing authorization can just kind of go into hibernation and you'd have a new one in the hospital. The lawyers are saying you can't have 2 authorizations at once. So I think we have to wait and see how that one actually pans out. But if you can plan it, you can have just one authorization, much nicer for all concerned.
Thank you. Next question is one that I'd asked on a previous webinar, so I'm really glad to see this one crop up. So this is about resourcing. We know that DOLS referrals were backed up in many areas, some quite serious backlogs with local authorities in particular struggling to get through those. What can we tell people on the webinar, Rachel, about resourcing for LPS and whether we think anything different might happen there?
Well, there are two elements to this. One is the enormous DOLS backlogs, which are being cleared somewhat. I haven't discussed in this webinar at all transitional arrangements. What will happen from day one of implementation of LPS, whenever it is, no new DOLS can be given, but any that exist will run on. So the local authorities are expected, as are other responsible bodies, to be thinking ahead and looking at their backlogs and thinking, can they get ready to do authorizations very quickly and easily, bearing in mind you can have these use of existing assessments. You could get all your ducks in a row to authorize for somebody before LPS came in, so that as soon as LPS does come in, you can do quite a lot very simply. The other bit of this answer is that LPS can, whereas DOLS was only for 1 year and then you had to go round the block completely again, all specialist assessments again, whole new authorization. This can be, you can have a first authorization for a year, then you can extend that for the next year, and after that you can extend it for 3 years, assuming that the person's condition hasn't changed and that the care plan hasn't changed. So in a very stable situation, you can, we will end up in a situation where there isn't this continuous churn of DOLS work needing to be redone every year. The other thing is, the other arm of this, I guess, is about financing. Money is being put into the responsible bodies to try and enable the system to run as smoothly as possible. I think in the long run it will. There are other resource implications, such as the training, which I think we are still waiting, it's fair to say. We're in a draft impact assessment situation, and it is silent on a lot of the detail that we will want to have some answers on. So I'm not quite sure if I've actually tackled the bit that the questioner was really interested in, or you either, Clive, come to that. Is there anything else?
No, I think that's really helpful, and particularly the extension response that you gave there, Rachel. I'm hoping, Amanda, that answered your question about extensions. If not, do type something else into the Q&A before we close. But no, I think it does, specifically around the extensions and how frequently these safeguards are renewed. That'll have an impact. We don't know anything concrete about the sort of financial resources, do we, at this stage?
Not really, because it's all still in draft. Yeah. And there is an awareness. I mean, huge sums are set aside for the implementation. If you read the impact assessment, it's all going to be way cheaper than DOLS. Well, I really believe that, I mean, it will ultimately be a bit, I think they've a bit fudged that myself. Please don't say I said so. But, you know, it's what they want to find, is that this is going to be, although it's expensive to implement, it's going to, but that's government direct funding. There's a certain worry about the costs.
Thank you, Rachel. So we are coming towards the end of our time for the webinar today. I've got one more question for you, and I just want to say, Shirley, thank you. Yes, we will come back to you on the question about adult daycare for people. The majority of the people you support are 70 years old. So we have got that question, which we will look into a little bit further for you. So the final question is from Karen. It's about capacity assessments. Currently, they're decision and time specific. I think you spoke a little bit about this at the beginning. Does any of that change at all with LPS, Rachel?
That is an extremely good question. No, it doesn't, because it can't, because it's governed by the wider Mental Capacity Act. You are absolutely right. What LPS does, however, is that where a person, say, has severe dementia or profound and multiple learning disabilities or an acquired brain injury that is not thought likely ever to improve, you can reuse assessments both for the mental disorder and for capacity carefully. And that is part of the responsible body job in their pre-authorization review. Is it reasonable to rely on this assessment? And there are people where, honestly, it's been a jolly easy job for the paid DOLS assessors to go out once a year and say, yep, still the same, and collect their fee. So I don't mind a bit that we can reuse, but you are absolutely right. It has to be still valid and applicable to the situation. And that is really essential.
Well, it's just time then for me to say thank you, Rachel. We will submit a Q&A response Q&A document after the webinar. We will put the slides onto the CPA website. So I just want to say thank you, Rachel. It's a really informative session. And just a final reminder that Rachel mentioned that we will be submitting a response to the consultation, but you are encouraged to do that yourselves and feed in. And as Rachel said, arguably your opinions are the ones that really matter. So do find the time to do that if you can before the 7th of July. Any final closing comments from you, Rachel, before we bring things to a close?
No, I'm extremely grateful to you. You have, I think, more than the other sessions on this, shaken my brains around a bit. I've had to think about the questions and answer them, and they've been extremely good questions. And I really do appreciate you taking the time and interest to join today when I know how busy you are. So thank you, all of you.
Thank you, everybody. We'll bring the meeting to a close then.